Good evening, everyone. I'm Rebecca Marsh. I'm the Director of Evaluation Research and Innovation at CASA Child, Adolescent and Family Mental Health. We're so glad that you could join us here today for the Dr. Roger Bland Lecture Series, presented by CASA along with our partners, Edmonton Public School Board, the Institute for Health Economics, the University of Alberta, and the Alberta Alliance on Mental Illness and Mental Health. The goals of the Dr. Roger Bland Lecture Series are really to provide information, to inspire reflection, and to spark discussion. This evening, we are joined by Dr. Ted Jablonski and a dynamic panel to explore self-care and the winter blues. But before we dive in, I'm really excited and honored to introduce Judge Dave Hancock, former Premier of Alberta, who is joining us here today. As you may know, Judge Hancock has been with the Provincial Court of Alberta since 2017 and was a member of the Legislative Assembly of Alberta as a progressive conservative until 2014. He was the 15th Premier of Alberta. So Judge Hancock has offered to say some words to start us off on this evening.
Well, thank you so much, and thank you to all of you who are here with us tonight, and those of you who are joining us on the live streaming, because it's so extremely important to be talking about mental health. And I want to start just by acknowledging CASA. CASA. I'm always told I have to say CASA, because CASA does such great work. I had the opportunity to work collaboratively with CASA when I was in the political realm. And now, of course, as a judge in the Family and Youth Court, each and every day, I see children, youth, and families who are benefiting from CASA's program, and unfortunately, even so many, many more who need CASA's programs. So thank you for being here. Thank you for helping to have the discussion on mental health issues and helping us to expand the knowledge of the community about the good work that CASA is doing. One of those good works is this lecture series, the Roger Bland Lecture Series. The next one, I think, is on children in care and attachment, and the one after that on addictions. And again, the work that I'm doing, those are both topics which are so essential for a greater understanding in the community. When I was Minister of Justice, 70% of the people, I think it's still true today, who are in our provincial jails had addictions, an alcohol, a drug, or a mental health problem. 70%. There's a lot of people who are cycling through the justice system, who are less productive in our society, less healthy for themselves, and of course costing society a lot of money. And if we're looking for a safe community as an outcome, we're not doing what we need to do to deal with those addictions and mental health issues. And one of the ways we can start is by talking about it and taking the stigma away from mental health in the community. Talking about how each and every one of us at some point in our life needs some help, whether it's from a friend, from a teacher, from someone who's close to us at work, because each and every one of us have mental health issues from time to time. Just as an example, it was mentioned that I was Premier for a while. 2014, best summer job I ever had. I was actually at the sod turning for the new CASA facility and joked that I expected myself to be in severe depression in 2 weeks, because it was 2 weeks before I was going to be booted out. And it was surprising to me the number of responses I got from people, not the ones in attendance, but people who'd heard about it, who thought it was very wrong to be joking about it. But I think it's important for us not to feel badly about talking about mental health and talking about our issues. When I left office, I was depressed for a good 6 months, severely depressed. I didn't get diagnosed as being clinically depressed. We don't need always to be diagnosed to understand that sometimes there are things in our life that just we need some help with. I gained about 15, 20 pounds, got all the illnesses I could get. We need to be able to bring these things out in the open and talk about them. And that's what you're here doing tonight, and that's why it's so important. We're talking about the midwinter blues tonight, but the takeaway from my perspective is if you're able to go home, talk to those around you, talk to people at your work about what you were doing tonight, why it's important, and why we all need to be able to talk about mental health, how it matters to each of us, how getting help is a good thing, no shame in it, there's no stigma to it. We really can benefit our community, and thank you for being here. I now get to introduce our moderator, Leslie McDonald. She needs no introduction. Leslie McDonald has been on our television screens for years with Global, and of course, heading up Women of Vision, doing a tremendous amount of work in our community, and moderating the Roger Bland Lecture Series.
Thank you. Thank you so much, Dave. Thank you so much for being here. You know, it reminded me, actually, when I was a news anchor for over 30 years. And when I left to start the next leg of my journey, I also went through a bit of a depression period. Mine lasted for about 4 months, where I just hid from people because I didn't want anyone to see what I was going through. And I hadn't even thought about that, Dave, until you mentioned that. So thank you so much for sharing, because I'm sure that there are a number of us in the room who've had some similar experiences. The Roger Bland series, this is our second year of being able to do this. It's about opening up the dialogue. And we have some pretty incredible partners who make it possible. I just want to mention it's presented, as we said, by CASA Child, Adolescent, and Family Mental Health, along with our partners, the Institute of Health Economics, the University of Alberta, the Edmonton Public School Board, and the Alberta Alliance on Mental Illness and Mental Health. And I say a sincere thank you for being a part of this series and making the series possible. I'm doing this. So I'd like to begin by acknowledging that we are on Treaty 6 territory, a traditional meeting ground, gathering place, and traveling route to the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. A few quick housekeeping notes. I don't know if any of you have tried to find the washroom in this place, but it's a little complicated. If you go down past the reception area, there's sort of that roundabout area, and the washroom is down there. Hopefully you won't have to in the next 2 hours. And just a reminder, because I keep forgetting to do this, please put your cell on silent. We love it if you tweet or whatever you do during the lecture to talk about it, but if you can keep yourself from going off during some really earth-shattering point, that would be much appreciated. The format this evening is we are going to have a speaker who's going to introduce the topic for us, and then we're going to have a panel discussion, and then at some point during the panel discussion we're going to open it up so that we all become part of the discussion. And I just ask that there's going to be an opportunity for you to speak directly with the speakers and panel members afterwards. So if you have a long story or something that you'd like to share, I ask that you wait and do it then, and keep your comments succinct and your questions during this particular session. That would be much appreciated. As Rebecca mentioned, the topic this evening is self-care and the winter blues, and I think it's quite fitting with what we've just been through. And today, all of a sudden, you know, the sun comes out and it's glorious and warm, and holy cow, I saw a woman in a car had a big toque on and big gloves and that kind of thing, who was probably a little surprised by how today turned out. But northern climate, it's really hard on mental health. Our keynote this evening, you're going to enjoy him. He is Dr. Ted Jablonski. He's an award-winning family physician based out of Calgary. He is the medical director of Jablonski Health and Skipping Stone Foundation. He's a sought-after speaker. He's a trainer and media spokesperson, and he also consults on sexual and transgender medicine. Dr. Jablonski is a recipient of the 2013 Award of Excellence from the College of Family Physicians of Canada and the University of Calgary 2015 Outstanding Family Physician of the Year. 10 years ago, he ran, cycled, and spoke across Canada to raise awareness of seasonal affective disorder, or SAD, and the stigma of mental health. And on a personal note, Ted is also known as Dr. J. He moonlights as a multi-instrumentalist, singer-songwriter, and he has 10 indie CDs to his credit. He's also a published author, and he's a passionate emerging playwright. And someone told me tonight that he also does seminars for doctors on writing. He drove up from Calgary to be here with us this evening, so please join me in a warm welcome for Dr. Ted Jablonski.
Thank you. Thank you very much. That's such a kind introduction. It's such a pleasure to be here this evening. I love speaking, I love educating. This room is amazing. So I was out in the corner trying to get a picture. I've given talks in a lot of places, but nothing like this. So this is quite something. So what are we going to be talking about? I sort of look up here when I speak. The real news on the January blues. So let me explain this. But before, let's talk about somebody I know very well. 40-year-old male. Can I turn your back to it? I can do that, eh? So 1 week ago, presented with extremely low mood, some suicidal thoughts, which scared him. Actually scared him enough that he had to seek professional help. Symptoms of very low mood, loss of interest, excessive fatigue, hypersomnolence means wanting to sleep all the time, significant weight gain, restlessness, agitation, struggles with cognition. That means thinking, memory, concentration, things like that. Particularly complex problem solving, word finding. He's a highly successful professional, supportive wife and family, long-standing mental health struggles through winter, but he was never really formally diagnosed with anything. He just would hang tight, and then finally the winter would go and spring would come and he'd get better and life would go on. Very healthy guy, but at this time things were not so good. Fitness was really starting to fade. He was on no medication, had no real diagnosis, but really was not the fit guy he used to be. Would drink a little bit excessively, particularly on the weekends after a hard work week. I need a break. What's, tendency towards that. Finally admitting that he could no longer manage his mental health. Felt that he had hit rock bottom at this point. So just keep this case in mind as we walk through seasonal affective disorder, winter blues. This person, right? So what are we going to talk about? We're going to talk about depression, talk about normal, what we call dysthymia, depression, seasonal affective disorder, or seasonal major depressive disorder, as it's properly called. I do want to speak a little bit about the stigma of mental illness and what we can and must do to overcome it. And then that self-care bit, the resilience. How do I keep healthy when I do struggle with this? You've heard my story already. I've essentially retired my family practice just to do work in sexual health and transgender health. It's a real need, and I've found that somehow I've wound up in this place and that I've got the passion and the expertise. So I've actually moved completely to do that. I still teach at the university and teach a lot of medical students and residents. I consider myself a public educator. I have a radio spot in Calgary, and I really enjoy it. I do media work on television, enjoy that. You've heard my artistic, the arts, I've been played in the arts all my life, and I really enjoy it. It keeps me healthy, and I'll never not do that. Who am I as a person? I'm a family guy. I have 2 kids, adult kids, 2 grandchildren. I grew up in Winnipeg. Very humble beginnings, but my sister and I were smart and hardworking, and she's a PhD ecologist who lives in the States now, and I wound up a family doc. But from those humble beginnings, you make your life. But the part that you don't have or haven't heard yet is that I have genetics on both sides of my family for significant mental health illnesses. I joke, and we do need to be light sometimes, but it's not a joke, but if you name the psychiatric diagnosis, I'll tell you who in my family has it. And it's on both sides. So I knew going into medical school that I was in trouble. At one level or another, I was going to get hit with something. It was just when and what, as all my family members have. The 40-year-old that I put at the beginning, that case, that's me, if you haven't figured it out. That was me 20 years ago. Right, I'm 60, I just turned 60 actually last month, and that hurts. I don't want to be 60, really, but I am, and that's the way it is. At age 40, I was a very unhealthy individual, and I had to look at myself in the mirror and say, you either are going to go down a very bad path, a successful guy with a wonderful family and a loving wife and all this wonderful things around you, and you can choose a very bad path, or you can choose to face it and do what you have to do. And that hurt, because I never thought I would be that one. I was too strong. I couldn't get mental illness. Despite the genetics, despite the fact that I knew it was going to come, it wasn't going to be me. I was going to fight it. I was never going to get it, and I did get it. So be it. So you pick yourself off the floor and you get moving. And what that meant for me is to get physically much healthier and mentally get much healthier, and both dragged each other along. I'll speak a little more as we go about that. So how do I keep my sense of humor? By things like this, right? Life is a sexually transmitted disease with a 100% mortality rate. That's true. It's absolutely true. And I do sexual medicine. I always show the slide. I love it, right? So let's get into it. Health. Health is a state of complete physical, mental, social well-being, and not merely the absence of disease, right? So I can have no diagnosis, but not be healthy, right? Health is a whole other thing, right? It's not just the lack of being on a medication or having a diagnosable disease. So what's happiness? Well, happiness is, to be honest, we think it's easy to define this. It's perhaps not that easy. Sense of well-being, joy, contentment, right? I think most of us, hopefully most of us, everyone has felt happy at some point in their life, but yet we worry about being blissfully happy. We look at people like, what's wrong with you? You're too happy, right? I mean, there's a little bit of happy, that's okay, but you can't be overly happy. You can't be happy every day. But why can't we? Why can't we be happy all the time? Let's talk about stages of happiness and what that's all about. If you Google how to be happy, 9.5 billion hits in 0.4 seconds. That's pretty amazing, eh? So a lot of people wondering how to be happy, a lot of people talking about how to be happy, right? And yet we struggle with that. So the term dysthymia, if you've not heard of it, if there's normal here, there's depression here, dysthymia is that somewhere in the middle. There's actually a term called chronic dysthymia, which is a medical diagnosable. I'm talking in this term about a dysthymia, and we all know dysthymic people. They're unhappy. They're miserable. Life is pretty good, but yet just nothing's ever good enough for them. And they struggle with this. And they're sometimes irritable, sometimes more angry. And perhaps they're not enough to diagnose them. Perhaps medication wouldn't fix them, but they're not normal. They're dysthymic. Depression itself is a mental health disorder characterized predominantly by depressive mood, loss of interest and pleasure in activities. And I'll go a little bit farther into it. If you want to make a diagnosis of depression clinically, or me as a doctor want to make it, I use DSM-5, which is our psychiatric Bible. And in that Bible, it says you have to have certain criteria. The two major criteria of depression are low mood and or decreased interest in or pleasure in things. You have to have one of those two in order to be diagnosed. And then there's a whole list of other things. So weight changes, sleep disturbance, change in motor function. That's being agitated or the exact opposite. I'm almost paralyzed. I can't even barely move. Fatigue, loss of energy, worthlessness, guilt, cognitive difficulties. I've spoke to that already. That's how I think, my thinking process. Recurrent thoughts of death or suicidality. So in order to make the diagnosis, you need one of the two or both, and you need a few of the others. It has to be at least 2 weeks or more, and it can't be connected to something else directly. So if we look at that list again, right, low mood and or decreased interest and pleasure, and the others. On this list, you're going to see a lot of physical things. So some people still believe, oh, depression's it's just in your head, and a true depression has a physical manifestation. It changes me physically. And I'll speak to that a little bit longer. But you'll see on that list are a lot of things that are not mental at all. Sleep disturbance, weight gain, actual physical energy. Not what I think my energy, the actual ability to do things is impaired. The thought process, you may say, well, it's in your head, right? Your ability to think, right? People who are significantly depressed have trouble making simple decisions. Most amazing example, I had a oil and gas executive running a millions of dollars worth of company, sitting in front of his sock drawer in the morning, spending an hour trying to figure out what socks to wear because he couldn't make a decision. His head wasn't there, right? When I personally struggle with depression, my vocabulary drops. All of a sudden, I can't get those words that come off my tongue when I'm writing or when I'm being verbose. All of a sudden, they're not there. So I'm speaking in a dumbed down language that just drives me crazy, but yet it's there. So the models of depression, we talk about what causes. People always say, well, what causes depression? And I don't know that we know the perfect answer to that, but there is a so-called biopsychosocial model. And in this model, if you look at this, there are three realms. So the biologic is the genetic, is my makeup, right? What are my genes and what diagnosis might I have, right? If I have diabetes or hypertension or problems with cholesterol, if I have a genetic abnormality, all these things factor into making me more vulnerable to being depressed. If I come from a social environment that's problematic, right? I'm unemployed. I don't have money to eat properly. I can't afford that, right? That has impact on the frequency of potential depression. Psychologically, how was I raised? Do I have the skills? Do I have resilience or not? Was I beaten down as a kid and never learned these skills? These all factor into this. So it's not only just genetics. It's not only just psychologic, right? We know people who've had amazingly horrific backgrounds of all kinds of tragedy, all kinds of problems, but yet never are depressed. It's unbelievable. Other people have all kinds of genetics, never get depressed. Other people, horrible social socioeconomic status, but yet never get depressed. So it's a conglomeration of those. If you talk from a more potentially scientific point of view, there's a so-called monoamine hypothesis. So this is that we have three major neurotransmitters. These are chemicals in our brain that help our nerves talk to each other, right? And those neurotransmitters, the three, are norepinephrine, serotonin, dopamine. And that in depression, we see usually people have very low serotonin levels. They may have low norepinephrine levels. They may have low dopamine levels. Most of our antidepressants, all of our antidepressants that are pharmacologic, play with 1, 2, even up to 3 of these neurotransmitters. The belief today, this was a theory that we talked about perhaps 10 years ago, 15 years ago, was very prevalent. Why? Because it seemed to make sense. If I have a serotonin-based drug, I give it to somebody depressed, they got better. So clearly that low serotonin must be at the root of depression because this antidepressant fixed it. Today we're thinking more, this might actually be more of a marker of things, that low level might be because our neurons are not healthy and they're unable to make enough, and it's the connections between them that's the problem. And what's caused that? And the manifestation or the fallout of that is these low levels. And if we treat them, we can help people get better, but it's really not really the root of it all, right? If we talk about the root of it, so it's dark now. That other slide was kind of light. I almost saw people for a while. BDNF, has anybody heard of it? You can just, yes, I've heard of it. No. So very little. BDNF, so this is a new concept, brain-derived neurotrophic factor. This is the underpinning or the precursor of everything else. And I'll explain that a little bit. So this is a group of nerve growth factors that support the growth, differentiation, survival of neural cells. This is what makes our brain healthy, what keeps it healthy. The more we have of this, the better our brain does. The bigger it is, the healthier it is, the more it keeps wanting to grow. There's a term we call neuroplasticity, right? The ability to we think of the brain is almost like a bone, right? You have a brain, nothing really changes. I guess going with that notion, I've never used this example, you break your bone. I guess you could break your brain if something happened traumatically to you. But the notion is we have plasticity. Our brain is constantly rewiring. Somebody has a stroke, it damages that part, but it's amazing how quickly the brain tries to map out new things so other things can work, right? And this is the chemical or the mediator of all that growth. functional MRI. So we now have the ability to look at a brain and look at the chemistry of the brain, what's active, what's inactive. When you look at fMRIs, things light up, right? So if somebody's playing music, that part of their brain lights up. If somebody's meditating, sort of different parts quiet down, other parts come up. You can actually see this in a visual way with lights. Let me show you this picture. I would say that anybody could say that these are distinctly different. The one on the right, or your right, is a healthy brain. The one on the left is a severely depressed patient. Those are dramatically different, right? That's visual, right? Oh, okay, so severely depressed, maybe things aren't lighting up as much. Big deal. The big deal is that when areas of your brain don't light up, they actually start to shrivel. In severe depression, there's parts of people's brain that are actually smaller. They lose volume. There's a term we use called pruning, right? You think of the nerves as a tree with a trunk, big branches, little twigs. In severe depression, it's like somebody's pruned off all the twigs. You see the messaging going out and then it stops, whereas in a healthy brain, it would go to that next level. So we are now believing depression to be a neurodegenerative process, meaning in the same world as Alzheimer's disease, with Parkinson's disease, that your brain is actually shriveling and you're losing volume. That's terrifying. And that puts us in a whole new perspective that is not just, oh, you know something, you're sad, you know, you better get off your butt and get moving or something like this. This is a serious chemical problem in the brain that manifests in all these things, including physical things. Some people believe there's an inflammatory condition. So where I'm going to go with that, if somebody has a heart attack, if they're depressed on top of that, their survival rates plummet. Much, much worse than if somebody's not depressed. Somebody has cancer and they're depressed. They're going to die sooner than if somebody isn't depressed. These things mediate each other. And they're potentially, some people are even starting to postulate that these are all one and the same. The same way you can get diabetes because of inflammatory problems or problems with insulin resistance, etc. Depression might be in the same realm as that, right? And we're just seeing it in a different way. We've never connected it, but it's funny how if you look at people with chronic disease, they're more likely to be depressed. If we look in the depression world, they're more likely to have chronic disease. So maybe there's more interconnections than we ever believed. These are not isolated things. Let's jump right now into seasonal affective disorder. So if you've got the main feeling of depression, which is terrifying, I'm going to tell you that, seasonal affective disorder is depression, but happening in a very specific season, right? Typically, it starts in fall, runs through winter, breaks up in spring, gets better through late spring into summer, comes again next fall. So the hallmarks of this, if you saw my slide about just depression, the features, we call this an atypical depression because the vast majority of people with depression struggle to sleep, right? Whereas this, all you want to do is sleep. You can sleep forever. Fatigue, loss of energy, similar. Weight gain. A lot of people get depressed, lose weight, right? This is a depression inherently where most people will gain weight. So how do you remember seasonal affective disorder? It's the hibernating bear. I just want to stuff my face and I want to go to bed and just wait out the entire winter, wake up in spring and carry on, right? And it's exactly that. And there are many potentially more similarities than dissimilarities in that model of talking about an animal hibernating. So in order, well, let's talk about seasonal affective disorder. So it dates back to ancient times. Hippocrates was the first to describe it. So this is nothing new, but interesting that only in 84 was it actually characterized and put in our sort of psychiatric Bible, per se. Is captured media interest? People, they find it interesting. That's why you're here, right? Talk about seasonal affective. People want to hear about it, want to understand it, because it's, being Canadian, this resonates with us, right? There is some skepticism within the medical community. This is the poor cousin of the depression, right? That most people struggle with this, really don't struggle with. They just don't like winter. Like, get over it, you know, move, right? So there's another variety of this, and we were talking about prior to this, before we came in this evening, about the reverse SAD, where people struggle in the summer, feel much better in the winter. And I actually have a colleague in Calgary who claims he has this, who lives for winter, struggles horribly with his mental health through the summer, which is very interesting. There's also some skepticism among psychiatrists that this actually is just a subtype of bipolar. Right? This is not a standalone diagnosis. Where this comes from is a lot of folks who do struggle with bipolar, and perhaps we're going to talk about this later on our panel, they do have a seasonality to their bipolarity, meaning they're more likely to struggle in the winter, maybe do better in the summer. They might have more likely to be hypomanic, manic in the summer, more likely to be depressed. But I'm going to make a case that seasonal affective disorder, or seasonal MDD, the depression only comes in the winter. It recedes in the summer. It's distinct. And it's not, well, off and on. No, it's very, very precise. Whereas with bipolar, there is not that precision. There's a lot of other features of bipolar which you do not find in seasonal affective disorder at all. So I do not believe this is a subtype, but I do appreciate folks who struggle with bipolar might have a seasonality to their issue. So how frequent? Winter blues are common. So when I went across the country, there wasn't a single person I met who, once they understood SAD, what is SAD? Oh, seasonal affective disorder, that's like winter depression. Oh, yeah, I've got it. My friend has it, my wife has it, my colleague. Nobody I met, not even a single person said, well, I've never heard of that. Never heard of it, right? Doesn't happen. So we are all we do know that this exists. Thankfully, most of it is minor, but 3% of Canadians could be diagnosed by criteria. The criteria you saw could be diagnosed and would fit within a mild, moderate, or severe category. The world stats are as high as 10% in some countries, particularly Scandinavian countries, who will identify this much actually more strongly than Canadians would, which is quite interesting. Severe cases, 1 to 2%. This is not the poor cousin of depression. People suicide with severe seasonal affective disorder. This is the true blue depression. It's more diagnosed in women than men. This is true of all mood disorder. Frequency is correlated with latitude. So if you learn nothing from me this evening, if you learn nothing else, please learn this idea. This is all about living away from the equator. It's all about light cycle. So people believe if I live in Saskatoon or Winnipeg, I'm going to have way less likelihood of having seasonal affective than if I live in Vancouver, where it's very cloudy. There's no sun in the winter. So even though it's not as cold, you don't see the sun. And I'm going to tell you it's got nothing to do with that. It's got to do with latitude, how far away I am from the equator. Why is that? It's all about light cycle, right? The farther you get away from the equator, the more the days shift in summer versus winter, right? Again, not about cloud or sun, it's how long the light hours are, right? If you're right on the equator between summer and winter, there's almost no season. The hour changes of light are very similar. The farther away you get, the more and more you'll see. So there is that, the land of the never setting sun in the summer versus the winter, where seasonal affective disorder would be by far the worst. So what's unique then about this is predictable. There are absolutely very few mental health issues that are actually predictable. The only other true correlate would be postpartum depression, where if a woman has postpartum depression, in subsequent pregnancies, she's very, very likely to potentially struggle with it. Doesn't mean she will guarantee have it, but she's got a really good likelihood. It's predictable, and it's something that we are on top of. We expect it could happen. We are just like right waiting. If it happens, we're right on it. We don't let it develop because it's got a predictable nature to it, just like seasonal affective disorder. Now, seasonal affective disorder, you don't have to have it every winter, but most winters you do. So if you talk to folks, they'll sometimes say, yeah, this winter was particularly good for some reason. I seem to get through it much better. Last winter was brutal. And usually it's not a winter that's more cold or like, it's nothing distinct about the winter, just something about that year was bad. And it's the majority of years. The cause is complex and not very well known, but the belief is this so-called dual vulnerability theory. that if you know, like birds migrate, bears hibernate, in the animal world, there is something in the chemistry that when the life cycle changes, my brain tells me what to do. There's some belief that humans have this feature. Not every human, but some have that genetic vulnerability. Now, if I lived on the equator, it would never come out. I would never have seasonal affective disorder despite that genetic. But if I live away, I have a genetic that predisposes me, and I'm living in a place that predisposes me. Put those together, boom, I get seasonal affective disorder. So that's the reigning theory, is that it works somehow like that. So the treatment I'm going to talk a fair bit about, but it's got to do with lifestyle, physical therapies, pharmacologic therapy, psychotherapy, complementary alternative medicine. When I went across the country, it was critical for me to talk to the media, to talk publicly in terms that I could remember what I was saying and something that might stick in people's head. So I made up the mnemonic SAD lamp, right? And that actually resonated. People remembered it years later. It's like, oh, I remember SAD lamp. Yes, thank you, good. Combination therapy is everything in this mnemonic, and timing is everything. So let's go through it. S, scheduled. Right? I told you, it's predictable. It's going to happen. We know exactly when it's going to happen. We were talking earlier, Leslie, in our discussion, classically seasonal affective disorder, I get asked to speak always in January. Media always talks to me in January. The problem doesn't start in January. The problem is that it's in its peak in January. It starts in October, November. So it's actually surprisingly early. But if you think about light cycles, that's when it starts to shift in the fall. It's usually those months. So some people's peak trouble is in November. You know, December, January, it's all, but November is the worst month of all. Fascinating, right? So there's individual variation, but we know winter comes to Canada every bloody year. It doesn't change. So we can predict, and we can actually schedule our therapies, right? October's coming, it's September, boom, here's what we're going to do. And we put things in place in September. We don't wait for January for Dr. J to give his talk and they go, damn it, I forgot this year, right? Antidepressants. Nobody wants to talk about this, right? Seasonal affective disorder can be managed without antidepressants, right? Maybe not. It's all about severity. If I have moderate or severe depression, that should not be managed with just lifestyle alone, maybe not light alone. I might need more than that. The teaching point here is antidepressants have very particular features to them. There's some antidepressants that are very sedative. They make you sleepy. There's some who are very agitating, really activating. Well, guess what I just told you about seasonal affective disorder? If I'm going to pick an antidepressant, I want something that's activating, that actually curbs my appetite, right? Doesn't make me want to sleep, doesn't want to make me gain weight, right? So you have to be very careful with what drugs are chosen. Now, we have great science, to be honest, with the standard antidepressants, serotonin-based drugs. They can actually work in seasonal affective disorder. But sometimes the best drugs are not those drugs. They're ones that are broader and particularly invoke dopamine, which is a much more uplifting neurotransmitter than serotonin. So antidepressants, there is a place in the moderate to severe. And so the oddity here is I have patients with seasonal affective disorder who are only treated during the winter, pulled off through the summer. That's very unique in depression. Typically, we don't do that. We treat through, and we, you know, maybe after a long trial, we might get rid of our meds. If somebody has chronic depression, we never get rid of meds. But in this world, I can titrate doses downward through the summer, ramp them up in the winter, or pull them off completely. That's very unique. Light therapy, so we joke about light therapy. A lot of people believe it works. A lot of people believe it's a complete hoax, that there's nothing to it at all. I'm going to make a case. I think it does work. I think we have good science. The problem with light therapy is it has to be used, and it has to be used almost every day. You can't use it once a week. You can't use it improperly. So I've had many people, like, they have a little light by their bed, and their eyes are closed and light shining on their head or something. I use light every day, every morning it comes on. No. So light therapy has to hit your retina. So just like your bear and your bird migrating, it's the light hitting the retina that sets up those neurostimulatory things. So my eyes have to be open. Doesn't mean I have to stare into light. It can be tangential, but my retina has to see that light. The light should be in the morning for it to work best, and it should be at least 30 minutes. So most people sometimes can't get that routine to get 30 minutes of light every single day in the morning. Why in the morning? I'm trying to trick my brain to think it's still a summer day. When does the sun rise in the summer? It's early, it's 5:30, it's 6 in the morning. I have to get up early and I have to get that light on my retina at 6 in the morning, 5, 6, 7 days a week. So you have to be unbelievably committed to light therapy for it to work. If you do, it's quite effective, right? Because I'm tricking my brain to think it's still summer. And if I can keep doing that through the entire winter, there's no winter. My brain believes it's summer all the time, right? I'd like to live in a place where it's summer all the time. Light therapy, you don't have to buy, the original light therapies were these huge banks of lights that took up half your house. My God. Now you can buy a light book. Is a Canadian company, makes a product, LED, which is very small. There's a lot of controversy. Do you need a blue spectrum light? Is it a full spectrum light? I believe a full spectrum is just fine. I believe the light book does work. The LED, you don't need fluorescent 10,000 lux, which is amazingly bright, brighter than what is on me right now. Right? So there are good products, but you have to use them properly. We might talk about this later in the panel if it comes up again. The other thing with L, I actually added in, so I just put light here, but do what you love to do, and I'll speak to that, and laugh, right? So there was my 3 L's, right? So complementary alternative medicine, controversial, what might be there. So I will speak to vitamin D. So some people believe that the treatment for seasonal affective disorder is vitamin D because Canadians have very low vitamin D levels through the winter. We know this, it's documented, it's proven scientifically. And because seasonal affective disorder happens in the winter, we have low vitamin D levels in the winter. Clearly, these two are associated. And I'm going to make a case. Second thing you're going to learn tonight, these things are not connected. They are not connected. Do we as Canadians need vitamin D through the winter? Yes. For our bone health, for our immune systems, to keep us healthy. But it's actually not a treatment for seasonal affective disorder. So that may be news to you, and that there may be a slight bit of controversy, but if there's controversy, it's not in the scientific world. The scientific world believes what I just said to be exactly true, right? So vitamin D, let's talk about vitamin D. If you were to supplement, you should start probably in the fall, all through the winter into early spring. We need sunlight to convert vitamin D on our skin. What's the rule of thumb? If my shadow is longer than I am tall, so actually off that light, see where my shadow is? It's actually longer than I am tall, and I'm not very tall. That means if this was the sunlight, I couldn't convert vitamin D today, right now. My shadow has to be shorter. That means the sun is higher in the sky as opposed to lower in the sky, right? I also need to have skin exposure, right? So we talk about 20 minutes of skin exposure. Nobody, in the summer, right? In the summer when my shadow is short, I need to be out in the sun for 20 minutes a day with skin exposed, right? No suntan lotion, right? We're terrified of the sun. We're going to all die of skin cancer. I'm probably going to go first because I love the sun. But we have to get out there and get some sun exposure first, then we can slather on our lotion. And we have to do it a fair bit if we want to convert vitamin D. So a lot of people who live in very hot climates, I think of like the LA kind of story. I leave my house, I go in my air-conditioned car to my air-conditioned building, go back to my air-conditioned car, back to my, I never see the sun. I live in the best state in the US, and I don't get any sun exposure. They will be vitamin D deplete also. So supplementation, how much there is controversy in that. Canadian guidelines should be 1,000. It probably should be 2,000. Should be probably even more. The belief today is that 2,000 international units a day for most patients is not enough. It does not give them an adequate level. Psychologist, so that's your P. It doesn't necessarily mean you have to hire a psychologist and see them, but it's a psychological therapies, right? So there's a therapy, CBT, cognitive behavioral therapy. Are people aware of that? Again, we're in dark? Yeah. Yes, good. I butcher this when I try to describe what cognitive behavioral therapy is, but here's my version of it. I'm driving up to Edmonton today, and this idiot comes from nowhere, cuts me off, and I go, "You idiot!" And I go, damn, these highways are busy and this is dangerous. And I'm going to Edmonton. I hate Edmonton. Like, oh man, what have I got myself like this? And I'm brooding over it, going over and over and over. By the time I get here, I'm angry. I'm upset. I'm angry. I'm like, damn, this was a mistake. I'm going to get home really late. Like, I don't know what the hell I'm doing. Versus, guy cuts me off. You idiot. I wonder why he cut me off. Like, probably something wrong with him. And God, the sun is shining. What a beautiful day to drive. I'm going to Edmonton to give a talk. I love doing this. This is the most wonderful. I come here and I'm just thrilled. I'm glorious. I see this wonderful setup and I'm just, life is wonderful. Exact same thing happened. This exact, and it's how we deal with that stressor. There's so many people in this world where you just throw one thing off, one little tiny stressor, and they're decompensate. And other people can take stress after stress after stress right off their back. Who cares, right? That's the difference, is their ability to manage this, and the therapy is cognitive behavioral therapy. There's another behavioral therapy called behavioral activation, or BA. I'll make a case this is really important in depression. So this is the notion, I will only do something if I feel like doing it, right? When you're depressed, you don't feel like doing anything. So this notion, I'm going to start to exercise when I feel like it. I just don't feel like it today, Behavioral activation says, I don't care if you don't feel it or don't feel it, you're going to do it today. You have to get up, you have to get going. By doing that activity, I will feel slightly better. By feeling slightly better, I will do that activity more often. By doing that activity more often, I will feel better. And it just sort of, one thing leads to another and it progresses out of it. But that first inclination, you can't sit in that. You can't wallow in it, right? When I struggle with depression, I'm a musician, but I don't play music. I don't listen to music, I don't play music. I just don't want to do it. And I don't socialize. I become incredibly introverted, get away from me. But I do know both those things help me, right? So when I really struggle with it, I start to play music on purpose, even if I don't feel like it, I start to feel better. I socialize, and when it's the last thing in the world I want to do, I do it. Knowing, right? Or I get dragged into it. It's usually my wife who drags me into this. You're coming whether you like it or not. And is that a good thing? Yes, it's a good thing. So that's a psychology. You can work with a counselor working through those things. So if we were to sort of go through that all again, right? SAD lamp, timing's everything. The reason for this slide, it's a combination therapy. I think a huge mistake we make in medicine is sort of one or the other, right? You're on medication. Oh, you don't need to bother seeing the counselor or psychologist. The medication will take care of you. Or the counselor. Oh, you're seeing the psychologist. Well, you're in counseling. Why would you need medication? Like, we're in counseling. We're going to work this through counseling. Why the heck can't we do both, right? So in this world, we can do exercise. We can do light therapy. We can use medication. We can see a counselor. We can do it all. And I would make a case, the more we do, the better we do, right? So this is sort of somewhat unique to seasonal affective disorder, but not unique. So in mental health world, we use combination therapies. It's really, really, really important to put those all together, right? So in summary, subtype of major depression follows a predictable pattern. It's very common in our latitude. It's a significant health problem. It's easily diagnosed and can be effectively treated with SAD lamp. So let me talk a little bit about stigma. You heard talk already a bit about stigma. David was alluding to it. I will allude to it in the exact same way. Americans love to hear celebrities talk about things, right? It doesn't exist until Dr. Oz says it exists, or Oprah Winfrey, right? No, we can't talk. Oh, she talked about. Oh, yeah, I got that too, right? We're not like that in Canada typically. It's more, what does our friend think? What does our neighbor think? What does our colleague at work think? But we only know what they're thinking if they talk about it. We have to just start talking about it. We were talking earlier about the Bell campaign. Let's talk. Is it working? Is it not working? It's a step in the right direction. I'm not sure if it's working or not, but the more things we do like that, the better we do, right? This could be a talk about prostate cancer. And if it was, a group of guys, I could say, oh, I had prostate cancer, I had my prostate taken out, and I had chemotherapy. How many in the room have had their, everyone would there'd be no trouble. In a room when we're talking about mental health, how many have been depressed? How many have tried to commit suicide? Nobody's going to go there. We're still scared. It's still in the closet, and we got to get it out, right? And I have to get it out. You all have to get it out. We just have to keep talking about it and not put anything on it. Now, the criticism for somebody like me is, oh, well, you're a privileged white male. Of course you can stand up and say nobody's going to come after your job. Well, maybe there's some truth to that, but that can't stop me from doing it. And I'm hoping that by telling my story, somebody can say, God, well, if he stood up and said, if he, had to take medication, maybe I have to take medication too. And that's the way it is. That's how we start this conversation. That's how we break stigma, just by kicking down that closet door. I'm going to spend the last little bit, just a short part, about self-care. So you heard about BDNF. The most powerful thing that helps BDNF is exercise. So we talk about exercise, we allude to it, but there's science behind this. And I talk about exercise way, way more than most other physicians because I think how important it truly is. And there's science that if I exercise, it actually improves BDNF, right? I'll talk a bit about value now, and less is great. So exercise, there's a wonderful YouTube video. There's a lot of things about BDNF if you want to do some research. But a lot of the stuff is very hard to understand, and it gets very complex, and it's people trying to describe it who perhaps are not the best educators. Wendy Suzuki, this simple little YouTube really did it for me. So you've heard about the runner's high, right? That's endorphins. Endorphins are morphine-like chemicals. So I exercise, and I feel this sense of euphoria or bliss, and it's wonderful, but it doesn't last, but it doesn't always happen. In fact, it rarely happens, but when it happens, God, it feels good. So that's what people like, oh, exercise is good because you feel that runner's high. Sure, that's part of it, but really the runner's high, the endorphin is a little tiny part of it. The other thing that exercise does is actually improve neurotransmitters. So serotonin goes up with exercise. Funny that. If we do this regularly, those improvement in neurotransmitters actually start to help that pruning, that neuroplasticity, and it's all through BDNF. The case she makes, and why I bring up her video, is that she likens it to going to a gym and building muscle. The more muscular I am, if I have an injury, it takes longer for that muscle to waste away because I have more to work with. If I can make parts of my brain bigger by exercising, even if I have problems and they start to shrink, I have more to work with, right? So she makes a case, neurodegenerative. If you have a family history of Alzheimer's disease, you have a bigger brain, it might take you another 10 years to actually have your disease when you might have had it 10 years earlier if you didn't have that extra brain material. So it's like a protective thing to have more of it. Interesting concept. So what do we have to do with exercise? There is some precision. So, because people say, oh, if whatever you're doing, just do a little bit more. That's great, and that's true, but it's quite precise. You need to do 150 minutes a week if you want to get the great benefit off of it. If you do more than 150 minutes, you might get other benefit. You might improve your endurance, etc. But the actual health benefits come at about 150 minutes. So break that down, 5 days out of the week for 30 minutes, give or take. The level of that should be at a level that I cannot speak in long sentences and not take a breath. I'm not working hard enough. Right? But if I talk like this, I can, that might be more than I need. So I should be able to speak in short sentences, but they should be clipped. Because I'm working hard enough that I can just, go on and on. So that's IKEA. You can wear, all the Apple Watch. Everyone's wearing technology to tell them what to do or not to do. Depends on what your heart rate is. So it's very difficult. If you have an average heart rate, this all works. If your heart rate is very, very slow, like if I did what I was supposed to do, compared to most charts, it'd be impossible. I can't get my heart rate that high. I have extremely low resting heart rate right now because of previous, lots of fitness after age 40. Right? So again, you use whatever you can. Type A personality, to remind myself. So when I'm in the severest part of my own personal seasonal affective disorder, I wake up early, exercise with a light on me. So I get a double hit right at the beginning of the day. So 6 in the morning, I'm either, I will do sometimes 7-minute work, elliptical, I have a stationary, my road bike on a trainer, and I have that light on me. So I'm doing 2 things at the same time. Because because that's efficient. I don't have time to mess around with this otherwise, but I have time for that one when I'm really, really struggling. 7-minute workout, if you've not heard about this, Google this. It is outrageously good. So it's not that you can get fit in 7 minutes. The 7-minute is a cycle, but it's a high-intensity interval training. So HIIT, 7-minute workout, right? So I just actually wrote an article about this for a medical magazine, the benefits of the 7-minute workout, right? You need a chair. You need a wall. So if you're traveling, you can do it. You don't need a gym membership. You don't need to be wearing fancy-dancy Lululemon clothes. You can do it in the buff if you want. You do it any way you want, but you need a wall and a chair, and you need 7 minutes. And if you get 7 minutes done and you haven't had enough, you do another 7 minutes. You get 14, and then it's 21, and it's 28. So I try to go for 6 rounds at a time, and I try to do that multiple days in a row, and it beats the hell out of you. It beats the absolute hell out of you. It's wonderful. I love it. Anyway, so that's a little practical tip, you know, because people say, I don't have enough time. You don't have 7 minutes? Really? You don't have 7 minutes? Right? Yeah, I got 7 minutes. Then do the damn 7-minute workout, right? Living in the moment, right? People who are depressed live in the past. What if that wouldn't have happened? What if? People who are anxious live in the future. What if that happened? What if this happened? What if that? So how do you break both of those? You live right now, right here, right now. You know, we were told this is a Hallmark greeting card kind of thing. Oh, live in the moment. But it's true. I learned this when I went across the country, you know, running and cycling. You live in the moment because there's long, long, long days. And all I cared about was today. Where was I needed to go? How many kilometers do I have to put in today? What's the weather going to be like? Do I have any media today? Oh, no, but tomorrow, I don't care about tomorrow. Where am I going today? You live right here, right now. You watch the road because cars are going to try to kill you. So you're in the moment all the time. That was life-changing to be able to do that for a couple of months, right? We can do this simply, right? So find value now, right? So when you're struggling in a day, stop yourself and take a couple of seconds. What is really good right here, right now, right? Get in that space. Not what's going to happen tomorrow. It's on Friday and oh, the weekend's coming tomorrow. No. Today, right here, right now, right? I am speaking to an audience who's hanging on every word I say. This is the best thing in the world, right? Right? And you could be saying the exact same thing. I'm sitting in the audience, and this is crazy. Doctor from Calgary? We hate those doctors from Calgary, but this is wonderful. I'm learning so much. I love this, right? Right? It's right here, right now, right? That's it. Less is great. This is my struggle. I've worked really, really hard all my life, so I've amassed some amount of, wealth. But I still have to tell myself, I come from very humble beginnings, from blue-collar family. I don't need all these trappings of wealth. So constantly trying to keep life simple. They say, there's stats. You need a roof over your head. You need to be able to eat. You need to have the basics. And after that, it's questionable that all the other stuff is going to make you any happier. And the happiest people are the people who have those basics. That's it. And they're happy, and life is good, right? And the most wealthy people are sometimes the most unhappy people, right? So it's not about that, right? So we need to learn to live with less. And particularly in, living in Alberta, I still have so many folks I deal with who really, they're unemployed. They're really, really struggling. They've been forced to live with less, right? They might have got themselves in trouble by living outside their means, right? I look in my own neighborhood, houses that are like freaking mansions or hotels. Like, who lives in these places? Why do you need a 10,000 square foot house? What's wrong with us, right? Why do we need 5 cars? Why do we, there's so many excesses we do, but we put so much pressure on ourselves that we have to do that. We don't have to do it. We can stand back and just keep a much simpler life, Easier said than done. And I'm saying I struggle with this as much as anybody else, but I think it's really, really important, especially living in a first world country where we have so much advantage and we do silly things because of that. I'm going to end right there. Thank you so very, very much. Actually, Before our panel, so I told you I'm an author. This is my first published book. Is there some way of putting the lights up a little bit? Ah, look at that. So, who was born in December? Okay. Who was born? Well, okay, I have to have dates then, right?
December 5th.
Close. Who's the other December babies? 15th? Yeah. 6th, 5th, that's 4, okay. 6th? Anybody else? Sorry? 28th, yeah, you're out of it. Sorry.
Right here.
The first? Oh. And where's the other? Doesn't matter.
Sorry.
I was born on December the 11th. You are the closest, you get a book. I hope you like reading. Oh, you're very welcome. All right, let the panel begin.
Hey, Ted, where can we get the book? Did you bring a case with you?
I brought a couple, but
this
is not a book selling tour.
But still, it'd be interesting. Thank you so much, Dr. J. Do you mind if I call you that?
Yep, yeah, please. That's everyone
Thank
does.
you. That was really good, really practical, and you gave us a lot to talk about in the panel discussion as well, to be able to elaborate. What I'm going to do is I'm going to introduce the panel members up to join us here, and then I'm going to spend a little bit of time. You're in the perfect spot.
Or here.
No, you're in the perfect spot right here. We want you in the middle.
I almost hurt myself there.
So you get to know the panel members a little bit, and then we're going to have a group discussion, and then we're going to invite you all in. I'm going to introduce our panel members to come up to the stage. Kate Pume is a member of the CASA Youth Council, which is a mental health action group that works to create a platform for youth-driven mental health. Kate, did I say your last name right?
Yeah, got it.
Good, yes. Kai Corvella, he's the Executive Director of the Organization for Bipolar Affective Disorder, and he also drove up from Calgary to join us today. And Janet Hancock is a retired 40-year educator and principal, as well as a member of the board of CASA, and I know they're thrilled to have you. Thank you. Thank you all in advance for the wonderful conversation that we're going to have this evening and for joining us. Yeah, it's a big deal. So Kate, we're going to begin with you. Kate is a second-year student at the University of Alberta, working towards her Bachelor of Arts degree in psychology. And then she plans to continue her studies in clinical psychology. She has a lot to offer. She has struggled with her own mental health, and knows the experience of being a patient in the mental health system. She's now a volunteer and advocate with a passion for supporting people with their own struggles and helping others to understand the issues that people dealing with these struggles go through. And as I mentioned, she's a member of the CASA Youth Council. I'm so happy to have you here and really appreciate it because you have a lot to say and a lot to offer. Just to give an idea of the background, your background, how old were you when you started having your own personal struggles?
I was probably about 6 or 7 is like when I started getting sort of like suicidal thoughts, and then probably when I hit like 18 to 20 is when I realized that it was going to be an issue.
Yeah, and we're going to go through sort of some of the background and then how the SAD fits in. So as you got a little bit older, by the time you were 11, it started to get quite
serious, yeah.
Serious. So what did that look like?
So that almost looked like I was in a lot of very unhealthy relationships. I finished 1 degree in design, and then I did work there, but I was still
depressed,
and I went back to school for psychology. And
but when you were young?
No, this is when, probably most current. This is when it started. I realized that this was an issue.
Oh, okay.
So it was probably when it hit my rock bottom. Would probably be starting at the U of A, and I was having suicidal thoughts, and I wanted to harm myself, and I had an eating disorder, and it was all just a little bit like coming on at once. Like it was like how we mentioned earlier, like you're gonna eventually get it.
Yeah.
Well, it came all in at once. It was like self-harm, eating disorder, and then I had a few suicide attempts, and what turned into a few, throughout the course of months, I probably had about 6 or 7 suicide attempts in 1 month.
Wow.
Constantly bringing myself to the ER, and the doctor's looking at you like, what's going on? Why isn't your family physician helping you out right now. Like, you belong here. We don't know if we should admit you. We don't know if we should send you home. We just don't know what to do right now.
What did they do? Did you get help?
Yes, I was actually in Ponoka Centennial for about a couple of days, getting some help for my mental health. And with Edmonton, it's very hard because limited beds, limited space, ER can't keep you for as long as they would like. So they have a system where, are you going to harm yourself right now? Do you have a plan? Yes. We should probably keep you, or we'll keep you for a few hours and then we'll see what happens. For me, I had to seek out help by myself without a doctor because my doctor didn't believe in like psychiatry or wanting to help or referring me to somebody who's a specialist. So I was very blessed to contact the University of Alberta psychiatric outpatient, and they took me in. And within
Did it take a long time to get in to see them? No.
When I said that I'm going through crisis, they probably made me wait about 2 to 3 days, and then from that, I've been working with a psychiatrist for about 5 years, and we made such a lot of progress. And I got help from the Royal Alec in the therapy side, where they had amazing programs such as the TIES program, which changed my life completely and really put me on the right track from total self-destruction to building up who I am today.
Wow. Let's go back, because there must have been signals.
Oh, yeah.
You know, so you hit a crescendo by the time you hit university.
Yeah.
But there would have been some pretty strong signals before that.
Definitely. I was into like the most horrible relationships. I was into the self-destructing ones where it was verbally abusive, it was physically abusive, and I stayed because I thought I wasn't good enough. I had so much anxiety that I was going to be alone for the rest of my life. And it was just, I'm not good enough, I'm not smart enough, I'm not pretty enough, and it just sort of gave me even more anxiety and depression to the point where I just didn't want to live anymore. I was like, if I don't have a relationship, what is there to live for?
God, that must have been hard on your family.
Of course, for my dad mostly, when he has the police coming to the door saying, I heard your daughter's is going to commit suicide, and my dad having to deal with it every single month for about maybe 2 to 3 months, and him looking at me in the eyes like, I just can't deal with police coming to the door at 3 a.m. anymore. I don't know how I can help. Do we need to get you in handcuffs to go to the hospital? Do we need to like call a specialist and have me pay for it, or my dad pay for it, obviously? So it was definitely a very tough time for a single parent like my father to raise a teenage girl to an adult girl who's struggling, and he doesn't understand the concept.
What was that impact on you?
I didn't want to be a burden to him, so after a while, like, I realized that this was affecting my dad's sleep, this was affecting my dad's health, but also, most importantly, mine and my friends and everybody who's close to me, worrying about me, constantly checking up on me. I think, for me, that was something I was like, okay, like, it's time to go get some help.
Did you recognize that it got worse at certain times of the year?
I think when you're sitting in the ER room waiting for a psychiatrist or a doctor to come in, that's when you kind of know, after, like, when they start memorizing your name, you're like, oh, you're back again, and you're like, yeah. This is an issue.
But I mean, you know, if we talk about seasonal affective disorder, what was that impact on you?
Probably around, the worst times for me was Christmas to late March, because it is those all-together, family, loving-dovey, like, stereotypical, all about family and togetherness, and that's when it mostly came in, because when you feel so worthless, like you can't turn to anybody or you don't have anybody, that's probably when it hits the most.
My niece committed suicide just before Christmas.
So sorry.
And you know, that's where you see the highest, it seems like the highest rate of suicide is over the Christmas season. Do you want to speak to that at all?
I think it's, this is my personal observation, is that at times at Christmas, everyone is so happy, families are so close-knit. If I'm not getting that, whatever I'm experiencing just feels worse, relatively speaking, right? Because everyone is seemingly so much better off than I am.
Yeah.
If you can survive Christmas, I find people seem to do better in January, because everyone sort of has a bit of a letdown. So now, relatively speaking, I'm sort of on par with everyone else. But it's just that Christmas time is a very difficult time for mental health of a lot of people. I will ask them about that. Like, Christmas is coming, is this a good time or bad time? Because if it's a bad time, we have to bolster things up.
Now, is this related to SAD at all?
No.
No?
I would say no.
Okay, yeah. Interesting, interesting. CASA, I just want to talk about your work on the Youth Council, and then we're going to talk about self-care after. Tell me what you do on the Youth Council, what that, you know, I know advocating, for example, is very important.
So I do like a range of things, from anywhere from going to the meetings and helping with the magazine, Unseen, which is our new published magazine with CASA, as well as we do education. So we go to schools, or we try to go to schools and get them to work with us on mental health, and using like maybe our slides and giving them suggestions on how things should work, as well as meeting like industry professionals and working with them for like facilitating things, as well as advocating for better mental health and more funding for mental health, as well as knowing stigma and working to end stigma in education and in all settings as well.
We had a panel here in November, very, very impressive group belonging to this youth council. And you know, how empowering it must be for all of you to come together and to be able to share and then to be able to do something about it.
It's crazy because we all come from different walks of life and different issues and different stories, and to have us all come together, especially in times where maybe funding and mental health is going almost down the drain, in this, starting to speak, where it's not focused enough or it's not appreciated enough. It's nice to have a group of people that's saying, no, we need to work together. We need to work with the industry. Let's not fight them, but let's work with them. Let's educate them as best as we can.
Okay, I have to ask, because I'm sure that there are parents, for example, or teachers who, or even social workers who are in the audience who are going, I know someone could really benefit from a council like this. How do you get involved in the council?
I believe we have a website, or you can contact one of, I believe her name is Stephanie. Yeah. So if you go to the CASA website, there should be a link for volunteering, because that's how I got involved, was through the website.
There are so many aspects to your story, Kate, and I'm wondering, before we move on, is there anything else on a personal level with what you've been through that you'd like to add that's important?
Definitely. I think, personally, people are struggling a lot, and we just keep giving donations to mental health, and we can't expect for donations to help everything, and I think we all need to take a little bit of responsibility in making sure our government takes mental health seriously as if it was cancer or a serious deadly illness. We need to, as much as donations are nice and they're helpful, we need more support, we need more money to funding. We need to keep this as a serious issue as any kind of illness, and work together and stand together united to hopefully make this an issue that's being known and aware, so we can all get help for mental health.
You know, you give me hope. You really do. Because what Dave talked about and what I went through, it wasn't that long ago. And totally different experience in different times. I mean, I didn't talk about it either. When I look back on it, it was pretty severe, but I didn't recognize it. Just like I'm sure a lot of people with SAD and what they go through, they don't recognize, they kind of poo-poo it, or they just keep to themselves until it goes away. So our next panelist, and we're so pleased to have you, is Kai Corvella. He too comes up from Calgary. I hate that highway. He's the executive director of the Organization for Bipolar Affective Disorder, which is a not-for-profit that supports public education on mood disorders. Kai is an active member of the Alberta Alliance of Mental Health and Mental Illness, the Calgary Mental Health Network, the Provincial Advisory Council on Mental Health and Addiction. He advocates through public events and presentations, community consultations, and promotion. He's a recipient of the 2014 Lieutenant Governor's True Grit Award. And Kai has very much to say about our topic on winter blues. And before you start, what's the True Grit Award?
True Grit Award was given to individuals, usually with a lived experience of mental health, who have worked in their communities. And I guess I was nominated and chosen. But so just my work in mental health.
Well, it's interesting because your background's a bit similar to Dr. J, in the sense that that your background is an artist and that kind of thing. And this is something sort of crept up on you, not something that something that just sort of happened. I don't think, it reminds, when you talk to me about your story, it reminded me a bit of a frog in the water that doesn't even recognize it's starting to boil until it starts to boil. What happened? Yeah,
because I think that when you're thinking about your life and sort of the course of it, there's sort of thinking retrospectively, there's sort of like little goalposts and signs of some kind of something's not there. Yeah. Now, in retrospect, even I had developed as a child, I had sort of this kind of existential feeling of dread, even as a young child. And so I didn't really recognize it as maybe anxiety and maybe depression. But as I got older, that just seemed to be more and more and more. Yeah. And I think, actually, when I think about it, I was presenting with SAD in my teenage years, going from October until about November, till about March. Now, recognizing, one of the things I think I really recognized was Christmas time. I was never very interested in Christmas. It was very stressful, and I probably wasn't the best Christmas guest. But, so as it developed, and then, so what happened was that I had periods of actual clinical depression. I went through university, and then it turned out to be bipolar disorder. That was caused by a manic episode that ended up through psychosis. So my seasonal adjusted part of my illness has always been kind of what I thought was a subset of it, but also independent of it, if that makes any sense. So at one time I was definitely exhibiting like, oh yeah, this is definitively more sad than a pretty checked in bipolar disorder. And yeah, that was sort of discovered early on, in particular with a psychiatrist in Calgary who said, yeah, let's start talking about what is that time of year and how does that look like.
So your SAD is really closely linked. You know, it sounds like the issues that you had with bipolar are closely linked with what you had with SAD.
Yeah, on the depressive side.
Yeah, yeah.
However, it wasn't severe enough to be a clinical depression.
Yeah.
It was definitely what you would call winter blues, or what I would call sort of a moderate to mild depression, but lingering all the time, and
So-
having, you know, certain things happening.
Did that mean you didn't take it seriously?
Up until I was 30, before I was actually, I just assumed that that's what was the nature of the way I was. I mean, I think I came from a Scandinavian family, which is like a father that was very dark and brooding, and it was sort of like this kind of like, oh, this is what happens. And so you become a part of that kind of family and that kind of thinking, and you just go, oh yeah, this is just, yeah, Dad's always like this every year. Yeah. And in Finland, in particular, you'll see that they celebrate Juhannus, which is Midsummer Night, and the whole country just goes totally crazy because it's the sunniest day of the year.
Wow.
And it's a kind of a celebration. So I don't know necessarily if, genetically speaking, from my family, that it was sad, but I know if, on both sides of my family, definitely there was mental illness. Yeah. And yeah, and I think, yeah, it has been a component of it, for sure.
You went to get help, and that's how you got involved in this organization. And you went on to make it your life's work.
Yep. So I was actually, I did degrees in art history. I was a fine arts, and I was also a teacher. And so my background was in fine arts and being an artist and working in artist-run centers and that kind of environment. And then what was happening, I ended up teaching for a bit, and then what happened is I went through a series of relationship issues. My father had died. A relationship was broken. So I think that what it did, it was accelerated my actual bipolar disorder to the point that it was expressed in psychotic mania, and then was treated subsequently after that. Now, I think the thing is that I didn't realize, and this is with a lot of people who have bipolar disorder, is that that mania was actually fueled by the proper treatment of clinical depression, which was an antidepressant. So it did the flip side. And that was the sort of determining point where, yes, indeed, you have bipolar disorder, so we have to treat you in a different kind of way than if you're just, you know, having winter kind of blues or major depressive illness, I guess.
Boy, that must have been fascinating for you when you're running this organization and you're running these clinics and that kind of thing, to see what other people go through and then to compare it to your own experiences.
Yeah, people express their experiences independently, so it's their real experience, but there's a shared commonality that occurs among people. I remember when when I was first facilitating as actually a patient that came into that group, and then I started facilitating, was that we would notice, especially from October until February, that people would come to our groups and they would be much more down than they would say. And they would really come out and really say that. We very rarely ever saw anyone who I would say were in states of hypomania or accelerated mood. So we had this thing that sort of people were going around, so I'm feeling really lousy, I hate this time of year. And that was a common kind of thing that happened. And that was quite often, and it would go from year to year to year. And so we'd see this in our groups, for sure. And even in our family groups. So when you talk to families and they say, well, I'm having trouble with my child or my spouse, they seem very depressed right now, and they're always depressed at a certain time of year. They're pointing out something that's very obvious.
Yeah.
And then all of a sudden you go, well, perhaps let's think about what that is.
Yeah.
That's, you know, if your spouse hates Christmas and still loves their family and doesn't like that time of year.
I'm married to one.
Yeah. I mean, there's something going on, and it's just, there's sort of things that people will suggest, and they'll go, well, I have carbohydrate cravings, and sleeping, like more sleeping. So it was like I always said to people, I go, you're in trouble when you sleep more than your cat. Because that's an indication that there's something definitely going on. And so, there's those kind of things that people will recognize. And I think especially for myself, because I've been in this kind of milieu of working, but also as a very kind of a studious patient, because I realized when I was first treated for bipolar disorder, depression, I forgot all the other things that go along with it. So I would still, have a couple glasses of wine. I wouldn't eat correctly. And like even within probably the last 8 years, is that all of a sudden I decided that I need to go to the gym, and I started swimming, which changed the whole trajectory of my illness. So I don't have as many of those kind of down and up things. It's more pretty consistent. And I think it's just because of that. Ted had talked about that kind of neuroplasticity, this resilience, this building of immunity, and it's helped a lot for me. And then also I follow a really interesting thing. I had this really interesting Chinese psychiatrist in Calgary, one of my first psychiatrists, and he said to me, he goes, you have to get out every day for 30 minutes. And he goes, do it in the middle of the day. Yeah. And I was kind of like, oh, yeah.
Oh, I'm looking forward to this whole discussion.
But, so anyway, so it turned out I think he was correct, actually. Not that I want to go out, especially last week, I just want to stay in, but yeah.
We all got hit with that. I'm going to come back to, and I want to learn more about the organization, but I also want to introduce Janet, because she's been sitting here patiently while we've all been talking.
That's interesting.
So Janet Hancock spent 40 years as an educator.
Hard to believe I'm that old.
You're not old. You're young. If you're old, I'm old, and so is most of the panel. It's just time for a different chapter in life.
Yeah.
And I love the word retired. because I bet if we knew what your schedule was like, you'd be anything but. For the last 8 years of her career, she was principal of Lillian Osborne High School that's in South Edmonton in Riverbend. She has long held the belief that the schools she runs should support students with mental health issues. And I understand you always found money in your budget to make that happen. Programs and that kind of thing. You are what I would call an early adopter or adapter. She's also married to Dave Hancock, and she sits on the board of the CASA Child, Adolescent, and Family Mental Health. Thank you so much for being here. Interesting. You know, I mentioned you were an early adopter. What was it? I mean, all that time in the education system, you're not the only one who was, but somehow you recognized very early, before a lot of other people started really recognizing that there was this need. Where did that come from?
Well, first of all, I have to say 9 years instead of 8 years.
Oh, okay.
That's okay. I just have to get that out.
Blame the media to get it all wrong.
I loved it. I loved being at Lillian, and
yeah.
A couple of my friends are here tonight from Lillian Osborne,
yeah.
and so that's really nice. To answer your question, I guess one of the things I'm the most proud of, and the reason I wanted to, I was happy to be on the CASA board, was that I have had the opportunity as a school principal to use CASA on several occasions, and I really believe that the work that CASA does is life-changing. And to get back to your question, so my first really major experience with working with initiatives around mental health was setting up the Way In project, which is a project that was with 3 schools, 3 junior high schools in Mill Woods. We were serving about 2,000 students and families. We found that there were very, very few services available in this area. And we were able to build a model that was a wraparound services type of model with the child and the family in the middle, and then all the supports around that child and family. And so supports that would be around the child and family would be things like the school resource officer. We worked very closely with the Family Center and had fantastic success working with success coaches. We worked with not-for-profit organizations like Big Brothers and Big Sisters. We had children's services were a huge part of what we did. And when we originally started the project, we worked very closely with what was ADAC at the time, because one of the first presenting issues that I had as a person new to being a school principal was some very significant drug and addiction issues in the community. So the only, to give you an answer to that is to say that as a school principal or as a school staff, not feeling very able to deal with the myriad number, the complexity and number of issues, and having to find a way out of that, and going home and complaining a lot to David, and having him say to me, well, instead of complaining, why don't you do something about it? And around that time, we were very fortunate because we were doing some work in this area. We were approached and asked if we would set up a mental health classroom by Edmonton Public School personnel and personnel from Alberta Health Services. And so we did. And that mental health classroom is still running, and it's running out of Edith Rogers. It serves 4 junior high schools. But that was a huge and significant impact on our work, because instead of working in a situation where kids had such high anxiety sometimes that they couldn't come to school or they couldn't be successful at school, we had a way of integrating them back into the regular classroom, but working with them in a smaller mental health classroom setting, and that classroom served the 3 schools and now the 4 schools. When I moved to the Twilliger Riverbend area, much different type of socioeconomic, but still very significant mental health issues coming to the fore, much larger setting, didn't have to rely on 3 schools coming together. We also had the mental health capacity grant at the time in that setting. But in the new high school, building a new high school, having to work with the community around the stigma associated with mental health, knowing that it was really important to set up a mental health classroom. So didn't try and do that in the first year, but did that in our second year. And that's a very strong program. And that's one of the programs that Norma, I was referring to earlier, Hartley, oversees as department head at Lillian Osborne. So,
Janet, what kind of mental health issues are we talking about?
So, just to finish that little bit. So your original question was, how did it all get started? And I think the way it gets started is that you feel like on your own, you're helpless, and there's not much that you can do. But when you work with others who have common interests, with children at the center, there's a lot that you can do. So we see a huge variety of everything that you would see with adults, you see with young people.
And more so, it just seems to be getting more and more and more. I know we're hearing about it a lot, you know, as we mentioned earlier, budgets are getting cut, and classes are getting larger, and teachers and principals and school system is having to deal with more and more.
With all of the budget cuts right now that we're hearing about and are impacting so many different areas connected with government and government funding. And I worry a lot about, because my passion, of course, is with children in schools, but I also worry about how in difficult times when we have these kind of challenges, that's when we rely on all of these types of supports that I'm describing, and yet those are often the areas that we seem to cut first. And so you look at Edmonton Public Schools, where we have had the benefit, especially in the last few years, of tremendous support in terms of Alberta Health Services putting either a therapist or an addictions counselor, in some cases both, into every single high school. I worry about what's going to happen in that situation, because we know that if class sizes get larger, not only does it impact and make an already extremely challenging job as a teacher difficult, but we know that that's going to impact children and families. And so where are those supports going to be to offset those issues? So yes, that is a concern.
So to come back to the other question, what kinds of things are you dealing with in schools?
Well,
I know it's a big question, but I to give people a perspective on, you know, when we talk about mental health, are we talking about more anxiety? Or are we talking, what are we talking about, more autism?
I think we would say we see a really high level of anxiety.
Yeah.
I think I mentioned to you, we chatted on the phone briefly, and I think I mentioned to you that I was very surprised when I was a principal to see in our catchment group, which represented elementary, junior high, and high schools within our catchment area, so within the Lillian Osborne, all the schools that feed into that big area.
Yeah.
It was very interesting to me to be hearing about mental health issues, primarily anxiety types of issues in that community. I would say elementary principals were suggesting grade 2, grade 3, grade 4. That was a shock to me.
Yeah.
But it, you know, not just that area, broadly right across the city. So anxiety is a big one.
Yeah.
Of course, depending where you are, poverty is enormous.
Yeah.
Violence in the home, addictions. That's why I'm sort of looking at you blankly, because it is a huge list. I don't think social media helps. I think what Dr. Jablonski was saying about what's happening in Calgary with all the people who've lost jobs because of the changes in the oil industry, the crises that brings to families, the stress that they're under, families, you know, out of work, having to find ways of coping. What does that do in terms of the level of chaos in the home, those kinds of things. But there's a whole spectrum. Social media doesn't help. As a high school principal, and earlier as a junior high principal, I was concerned about the amount of bullying, the ease with which we're able to bully now from anonymity, because as we know that can happen. We have issues, all kinds of issues, right? Sexual abuse, you name it. That's broad spectrum of issues. What I wanted to talk about, though, was how we can operate more from a perspective of hope. And what I wanted to talk about was that we can build school cultures that have work more from a kind of a preventative, more of a proactive way, if we're looking at building resiliency through developing a culture of caring and openness. And so one of the stories that I wanted to tell, I'm a little fixated on Norma tonight. I don't know why, Norma.
That's because you sat in the front.
Probably because you're sitting right there. I used to do this all the time to the teachers, and then I'd make them get up and talk. But anyway, I won't do that right now.
Oh.
But I was just going to say a story that Norma just told me that I love, that speaks to openness, that's about her. And this speaks also to being present. I think it's so important to be present. And so I really liked hearing you say that as well. And one of the things that made me think about this story was that Norma was, as a counselor, she was getting out of her office. She was in the hallways where all the kids are, you know, in between classes. And something that she likes to do, she likes to get out and get around and be visible, even though she's extremely busy as a counselor with her own one-on-one counseling and so on. And there were a group of girls sitting at one of the tables. And as she went by, because she was present, she heard part of their conversation. And she decided that it was interesting enough that she should stop and hang out for a bit and participate. So she did. And when they were talking with her, she was listening and encouraging them and laughing and so on. The next day, one of the kids from the group came in and said to Norma, made a point of coming into the counseling office and said, you know, what I've really been thinking about, Mrs. Hartley, is how great it would be if you started a girls' group for us, and we just had a girls' group and we met once a week. Well, on the surface, that sounds social, but I know from experience that probably there were some pretty significant issues that this particular girl knew about with her friends and wanted to be able to bring to a caring adult. So I mention that as a small example of how being open and caring and present can make a huge difference. And especially when we're in these challenging times, when we're able to do that, not just as teachers with students, but as teachers with other teachers. And so when I think about some of the concerns that I have about, you know, what's happening right now in the schools, I think it's really, really important that we are present, that we're able to do that. And there are lots of kinds of things that we can do.
What are some of the things that you did at your school? Like you said that you noticed in the school that it went from November to March with some of the things that your students were dealing with. What were some of the specific things that you did in the schools that really made a difference you noticed for students who, I don't know, maybe I should have asked you the question before that about whether or not you saw a real dip in what was happening with how students were feeling during those winter months, and then some of the strategies that you used.
Well, I think you've got a couple of questions in there.
I do.
So one answer would, a simple one would be to do things like, you know, if you're looking at staff morale, and I think we do all these kinds of things, but, you know, to have potlucks or to have soup days or, you know, to bring in, you know, drinks, whatever, smoothies or whatever during the day and take those around, you know, things like that. I know at Lillian Osborne they do something called pop-ups, which the Students' Union leaders do, teachers with the kids, and they'll have an unannounced surprise something happen. So maybe one day it's bubble tea, or another day, you know, when it was cold, it was hot chocolate. Little kinds of things like that. With staff, I think it's really important to, again, be very aware of what's going on. So if someone has had something happen, maybe they've lost a pet or something like that, it's important to bring in a plant or a coffee or put a note in their mailbox, things like that. One of the things that I always did, that I loved doing, was to piggyback on as a teacher would tell me that they had had a success with a student, I think it was really important to acknowledge that and follow up with that. So one of the things that I would do is if I was having a bad day, I always did this, and say I just had a really bad meeting with a parent or something, and was not very happy about how I was feeling. One way that I did that was a bit of my own self-care was I would get in contact with that teacher, because that teacher would have mentioned that to me maybe the day before or something. And I would ask them to come down to my office, and we would call the student down they had had this success with. And I loved doing this. It was lots of fun. And the student would come in, we'd talk to the student. The teacher would talk about why the teacher had shared with me that they had had this great success. And of course, the student coming into my office would initially come in under some trepidation, thinking they were in trouble or something. And we would be very positive with the student because we would be very excited. But the big part was then we'd say to the student, would you prefer us to call your mom or dad? And of course, they always have the cell phone number, so that's easy. And so they might say, I'd like you to call my dad. So we'd call the dad at work. I would usually start the conversation with, this is Janet Hancock, and I'm just letting you know, nothing for you to worry about, And then we would just say why we were calling that day. The teacher would go on the phone, and then we would have the student go on the phone. And of course, it was a very uplifting thing for us, because what would happen would be the student would be beaming and would leave the office a very different child from when he or she came in. But more importantly at that moment, the teacher, because maybe it was the teacher also needing some boosting, would leave the office feeling that way. And I just think there's so many things like that that we can do. One other example I'll give you is our success coach, Matt Weeb, at Lillian Osborne. And he did this. He was also with me when I was at Dan Knott. And Matt works for the Family Center, but it's also a partnership with Lillian Osborne High School. And what Matt did at both schools was he came up with this idea of starting a League of Extraordinary Gentlemen. And what was really fun about this idea, and he has so much success with it, it was his way of pulling together a group of boys and having a boys club, a boys group, and having a way of working with some boys that he felt maybe were a little disenfranchised in the school or needed a little bit of extra support. And
Janet, I'm going to have to cut you off. I'm so
sorry.
sorry. This is totally off topic, and we've only got 15 minutes left.
I'm sorry.
Sorry. I just, because I want to get back to the SAD issue, and one of the things that you said, actually, that I was really surprised. You said 3% of people, are affected by SAD. And yet, when you talked about that 40-year-old who was you, poor Kai sitting next to me, and I'm going, well, I'm hooped. How many other people felt that way? How many other people recognized in themselves a lot of those symptoms that Dr. J talked about? Yes? Honestly? Yeah. I mean, if there's different levels, there's different degrees.
Yes.
And I think that's one of the things that's so, I don't know, maybe the reason why it is a bit like the frog in the boiling water, why it takes a long time for us to recognize what's going on, because there's a bit of that in all of us, I think.
And it gets better.
Yeah.
Right? If you wait long enough, spring comes and you get better.
Yeah.
So you're always looking back, oh, well, that was just an unusual winter, until you realize the last 10 winters were unusual bad winters, right?
Yeah.
You just don't connect the dots because spring always comes.
Yeah.
Right.
Did you recognize that with yourself?
Definitely.
Yeah.
I've noticed that certain times I'll be super down and I don't want to move, and then by spring and summer I'm feeling totally energized and ready to move and exercise as well.
As well, Kat? I know that you were nodding.
Oh, yeah, definitely.
Yeah.
Definitely. And I think, yeah, definitely early on, like in my 20s and 30s, definitely there was that seasonal component that's always existed. And also, I sort of, for myself, excuse me.
He came up here with a sore throat and a cough.
So anyways,
Yeah.
I think that my seasonal affective disorder also related to the fact that I've been in post-secondary for far too long. And it sort of matched the times of I think there's students in the crowd here and teachers would understand this as well, is that it seemed that my seasonal affective disorder happened at the wrong time of the year. And it would start at like midterms and then it would go to the, middle of the next midterms. So I think for myself that actually that pattern was kind of a part of that whole kind of thing, because, you know, I think that if we use the term episodes, they do change over time and they have different trajectories depending on experience. But, you know, I always felt that there was always this underlying. There was always that sort
So
of
is there
under
any
the
advice that you
surface.
have for people who, you know, to help other people recognize that this might be something that they're dealing with? And even with students, you know, what do you see? How can people recognize that this is something to pay attention to and to take seriously? Because we tend to kind of go, oh, it's not a big deal.
So I'll make a comment.
Yeah.
It's funny, I do a lot of work with transgender folks. So speaking of gender is a bit odd in the context that I'm going to, but men, or a more masculine way of getting depressed is to be angry and irritable. A more feminine way is to get more moody or tearful. So sometimes if you see somebody who's unusually irritable and angry, that actually might be their manifestation of depression, right? And that's something that sometimes flies under the radar. You know, why are they so angry? Why are they so irritable? That's their depression.
Wow. Self-care. You know, when we were on the phone, wow, did you ever have some incredible suggestions about self-care? And I want to know about the glitter box.
So yeah, so the
Or
glitter
glitter
globe.
gobe.
So, okay, so we made those in the TIES project, which basically means you could be feeling whether super depressed or suicidal or anxiety, but the key point is when you make it is when they all fall to the bottom, if you still have those issues or that anger or that anxiety, that's when you go seek help, that's when you talk about it. Sometimes you just need some time to yourself just to focus, relax, or do whatever you want. And sometimes we overreact or we throw like irritable to other people and snap. It's important that once the glitter goes down, if those feelings are still emerged and you still feel very tense, that's when you seek help to talk to anybody, a friend, a family member, a professional.
So Kate has a self-care box. I am so impressed. Tell us what's in it and what you use.
Basically, it's my iPod, which I have a playlist on there of all like positive music and very upbeat, as well as like a blanket or like a chocolate, something to make me feel better, as well as obviously the blanket to keep me warm, things to make you feel almost a bit whole.
Yeah.
So things to make you, maybe if things aren't going well right now, it gets better, or if I don't do the glitter box, if I know I'm going through a tough time, I will write on my wall or on like a sticker and then put it on my mirror being like self-positive quotes or affirmations, just to kind of get me hyped up in the morning.
Wow. What are some of the other, because you have a number of strategies that you use.
I think my most one is if I know I have symptoms and I can tell my symptoms, I seek help, no matter what, whether it be a therapist, whether it be a family member or a friend. I really try to reach out. And another huge one is exercise, and we've talked a lot about that. I go to the gym 5 days a week, every single day, and I've noticed, especially during the cold break that we had in minus like 40, I didn't go to the gym for that week, and I noticed myself irritable, anxiety, like depressed, staying in bed all day, and I realized that it really did take a toll on my body, and how crazy it is going to work out for, even if it's for 2 hours or an hour and 30 minutes. You feel better, the endorphins are hitting you, you're happy, you're a little bit positive, and you actually went out. That's a huge thing with me, is whether I'm anxiety or depressed, I go out, whether it be outside for a walk, whether it be to the mall, just to physically be out there instead of doing negative habits like staying in bed, moping around, playing on my cell phone.
Because you also have a number of strategies that you've used to help.
Yeah, over the years, definitely. Kai, yes. Great. Yeah, all kinds of strategies because having had major depressive illness, you just don't want to go there. And so the strategies have been developed over time, trying to eat better, limiting the amount of alcohol I would drink, being sort of very moderate in things that I would do. I've actually watched my diet really, really well because of the nature of this time of year. My inclination would be is that I would like to eat a bunch of chocolate, whereas, and some sugar and fat. And so I've made things like I don't keep certain things in my house, which is really, I hate that, but it's very necessary. It's very necessary. You know, it's like put away that bottle of wine. You don't need it. Get outside. Getting outside is a really important thing for me. Is to get outside, and then to have some physical activity. But I also have I have a relationship with the people that I work with who work for me, and I have a sharing group that's not necessarily independent of what my agency does, but it's us getting together. And there's some of us that are actually working and dealing with bipolar disorder, dealing with SAD, and that's actually gives us a lot of strength because sometimes people don't necessarily want to bring their families always involved in it or their friends, so that they can come together with us and then have a very sort of candid conversations. So that peer support was kind of an integral part of my sort of strategies for dealing with this type of SAD or depression. And it goes to what my group in Calgary does, which is a support group. So that sense of community has always been an important part, whereas actually I'm quite introverted and I would prefer not to actually go outside of my house, but it's good for me to do that. And yeah, those are the strategies. And then if it gets really bad, then I have to go see my GP or my psychiatrist and say maybe there's something that we have to adjust. Because basically, if you have bipolar disorder, you're on a maintenance level of medication, and sometimes that is not enough to treat depression. And that's what I keep telling people, especially over the years, is that the people will go into their physicians and say, give me something that's going to get me out of this, and I need it now.
I need a silver bullet.
And it's so, it's like, okay, I want you, you'll like this combination. I want you to give me I asked the psychiatrist once, I go, give me a combination of Wellbutrin and Effexor, and I want to jack it up, because I want a rocket ship out of here. Right. Okay, so that's okay, except there's a lot of, for bipolar people, they would understand, but that's just not enough, and that's not the strategy. It's a multi-strategy. Like I have been in psychotherapy off and on for years, and what that component was is to isolate things that were bothering me that would manifest itself in more depression and more anxiety. Because part of the thing is that we have talking about anxiety in students is that depression and anxiety are sort of like cousins. They're there. Yeah. And what I found is that I had to find a way to reduce anxiety to a certain degree so that my depression wouldn't be that bad. And so this is a kind of holistic attempt for wellness. And it's, I used to always believe that there was only this way and this way would work. And that was just not working. And I've been working as a community person with a group out of UBC called CREST-BD, which does psychosocial treatments of bipolar disorder. And what it does is to look at those components of your life and see is that what's your relationships like? Are you happy in your job? Are you dealing with your finances? Are you seeking out a sense of spirituality? How's your diet? And all those kind of components of trying to go, which doesn't happen with me a lot, but to try to go, let's do this kind of inventory. And what is the inventory going to say to do or not to do? Because, for a lot of people who are depressed, especially for males, there is, I think, a need for self-medication. And I think that you'll find that, especially in younger men, where it's just like, okay, I'm going to feel, I'm feeling really lousy, but I'll go have a few drinks and then I'll feel better. So my friend called it the 2-drink buzz. You always want to get back to that point. So that's sort of like a negative thing that happens. So I've had to really, not that I'm always successful at it, but I've had to try to do multiple things.
So just, the sense that I'm getting from all of you is that, they're all linked. And sad and things that people go through with winter blues can be on its own, but most of the time it's linked with other things as well. And that there's no one thing, it's a combination of many different things.
Absolutely. If I can speak to your point about alcohol is a depressant. Yeah. So if people who struggle with anxiety and depression are never made better by alcohol, ever. So it's one of those things that particularly people with SAD have to be very, very careful through the winter months that's not where they go to self-medicate, because that's a very common mistake made. I'll drink a little more and maybe I'll feel better. It doesn't work. It just makes it much worse. The other comment you made, and I'll speak to it informal, the so-called like a buddy system is really important. Yeah. So, but it's really important how it's set up. So my buddy, and this is a mental health buddy, could be my spouse, but it could be my best friend. It could be a colleague at work, but that's potentially problematic. But that buddy, the deal with the buddy is that when they see you struggling, they can say something and you can never say anything back in return. It's like, oh no, but it's no. When they observe something and they tell you something, you have to do what they tell you. That's the arrangement you have with them because they're your best observer. And typically this can be a spouse. And it's a difficult relationship when you're in the middle of it because you're fighting. It's like, no, you're wrong. No, I'm not that bad. No, but you have to learn to, when the buddy catches you and says, listen, you're in trouble here. Thank you. You say thank you and you believe it and you have to do what you have to do. Yeah, and then again, it can be your where you have your inventory then. Okay, if I'm getting caught out and my buddies told me, now I have to do, I have to do something. I can't just let it go because my buddies caught me.
That brings up a good point because Janet, one of the things that we talked about was social media. And kids, and that's the difference with this generation with anxiety and bullying and that kind of thing. They can't get away from it. I think it was you who mentioned that most of us, what we used to do, you get bullied in the playground, you go home, you close the door, and you get a reprieve. Well, these kids don't get a reprieve anymore. And well, how is that? I mean, I don't know what this has to do with SAD, but it exasperates. I just can't remember the problem. It makes it, exacerbates the problem. It just makes it worse. What are you seeing? What did you see in the schools?
I just want to comment on the buddy thing. I love it.
Yeah.
I think it's a great idea.
Yeah.
What you guys are talking about, and to me it makes a lot of sense.
Yeah.
I'm hung up on the culture thing because, so this is actually answering your question, in case it doesn't sound like it is, and I'll be shorter. Because I think if we're talking about getting away from the stigma that's around issues with mental health, our workplaces, whatever they are, right? Schools or whatever. I think the buddy thing is a great thing to have. And I think that's something that could be applied universally. I know part of what I used to do, and I really got into it the longer I was a principal, I think because it was very rewarding. I really did try, and I think they call it emotional intelligence. I don't know if that would fit me or not, but I did really try and be present as much as I could given the nature of the job of being a principal, to notice and observe my team. And I know my team did that with the team. And I can't stress that enough.
Yeah.
And that's why this buddy idea is a wonderful thing. And you could even formalize it a little bit in a setting like a school or some other kind of a setting. And because part of what we're talking about is also if we're talking about self-regulating, it's being able to call it. And then, you know, once you know what's going on, by calling it, to be able to then have your strategies that you can use. And a buddy could definitely help with that.
And teachers supporting teachers as
Oh,
well.
absolutely.
And the system supporting teachers, because they need, you know, they always say, you know, the parent should have the oxygen mask first. And teachers need to be taken care of as well.
Another huge important point that you made about the how social media ties in, especially with SAD, is when you have a social media is very filtered, it's very perfect life, especially in the holiday season where you see everybody's happy, family and smiles beside the Christmas tree. And if you don't have that type of family, or you're estranged from your family, it can be daunting seeing the perfect life. And we don't click in social media that it's not really real. It's exaggerated in social media. They probably have their own issues, but it's not caught on a small pixel screen.
I don't participate. I hate to say it, but I don't participate as much in social media because I just don't believe in putting everything, my whole personal life out there. And, but it always seems to be about doing the perfect thing. I see people at parties where, you know, where they will do something outrageous or whatever and take a picture of themselves with friends about what a good time they're having and put it up, and it's just not. Anyway, actually we're over time, and I apologize. We have not opened this discussion up to the floor. I think with people leaving, that's a pretty clear indication that people are ready to wrap this up. But before we do, I just want a final word, and I apologize, there's quite a few things still to talk about, but a final word. What would you like to leave the audience with before we go?
I think the most important thing is there's a huge thing called mental health and mental illness. We all have mental health, and we definitely need to take ownership of it, and if we see the signs, we need to act quickly, because it's like any other disease. It's going to affect you in all aspects of your life, and don't be afraid to call out for help, because doctors are there to help. Your brain is another organ. It's something that you really need to take seriously.
Wow. Okay, I'll leave you to last. How about that?
Okay, fair enough.
Kai.
I'm going to give just a quick sort of my advice, and it's about light. Is that get some light during the day and turn off that light that you're looking at before you go to sleep, and turn that thing off an hour before, because that's what you need. Because if you don't, you're going to still be processing information. So get some light in the day. Turn that light off an hour before you go to sleep.
Oh, good advice.
Yeah.
Janet.
Okay, I would just say keep the main thing the main thing. So with the stresses that we're under as educators, for example, keep your focus on what's important, which is the kids.
Yeah.
My final message is a positive one. I mean, we've come a long, long way. We've got so much longer way to go in society, but I think at least we're having things like this, discussions tonight. We're opening up. We're learning so much more scientifically. So if people are struggling, we do have strategies. It is work, to your point, right? You have to put in the effort, but if you do, I think the outcomes are better and better, and the future's looking bright. So I want to leave on a very positive note.
And I really liked too, Janet, when you opened up and you said hope. It's about hope.
Oh, absolutely.
So thank you so much to our panel. It's been, it's an interesting, it's an interesting topic, because it encompasses so many other things, and it's hard to get specifically to that topic. So I want to thank you, but before we go, I want to ask Rebecca Marsh to come back up, because she has a couple of quick things to wrap up on, and some gifts. We have some talking bowls. They're original pieces of art for our panelists. And here, I don't have does she have a mic? Can she have a mic? Okay, thanks. Teacher voice. Yeah.
Thank you. So thank you to our panel, our moderator, our speakers, everybody, and all of you for joining us here today for this really important discussion. We just want to end on a few sort of housekeeping notes as well. The panel and speakers will be here to answer any questions. We do need to leave the building by 9 p.m. when it shuts down, so please be mindful of time. But otherwise, please come up and engage and ask your questions. Also, fill out the evaluation forms. I know I'm particularly invested in that as Director of Evaluation, but please fill out the forms and give us your ideas about what else you want to see, and list those on there as well, and anything you think we can do to improve this. And finally, please follow us on our website, through our social media, through Facebook and Twitter, and find out about when our next events are. And thank you once again, and have a safe and wonderful evening.
Thank you. And I'd just like to add one more thing. Tonight has been taped. And so in a couple of days, maybe within a week, you can go online, and if you wanted to go back and see something again or show someone else, it will be up on the CASA website. So thank you. Have a great evening, everyone. Thank you.